If you would like to claim continuing education credit for attending today's session, register with CDC's Training and Continuing Education online system and search the course number on the screen for the Hospital Sepsis Program Core Elements webinar series.
Thank you for joining us for the second installment of our Hospital Sepsis Program Core Elements webinar series. Before we get started today, I have 3 disclosure slides to show related to the CE that's being offered through CDC's Training and Continuing Education online system. I will advance through them slowly to allow you time to read. The first is the following accreditation statement. This webinar is accredited for CME, CNE, CEU, CHES, MCHES, CPE, and CPH. I will now share with you the following disclosure statement from CDC. CDC, our planners and presenters, wish to disclose they have no financial relationships with ineligible companies with the exception of Dr. Erica Kaufman-West, and she wishes to disclose that she was on the Speakers Bureau for Gilead and AbbVie for hepatitis C. All relevant financial relationships listed for these individuals have been mitigated as she has divested the financial relationship. Presentations will not include any discussions of the unlabeled use of a product or a product under investigational use. CDC did not accept financial or in-kind support from any ineligible company for this continuing education activity. I will now share the following joint accreditation statement for pharmacy education. Please read at your leisure. I am excited to welcome you to the Centers for Disease Control and Prevention's 5-part Hospital Sepsis Program Core Elements webinar series. These core elements will help U.S. hospitals implement, monitor, and optimize institutional sepsis programs and improve sepsis outcomes. They complement existing sepsis guidelines and help facilitate the implementation of guideline-recommended care practices at a wide variety of hospitals and healthcare systems in the United States. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. As you know, anyone can get an infection, and almost any infection can lead to sepsis. Sepsis is the body's extreme response to an infection. The CDC estimates that about 1.7 million adults in the United States develop sepsis each year, and at least 350,000 of them die because of it. The key to improving sepsis outcomes is early recognition and prompt treatment, requiring everyone's vigilance. We've put together this in-depth series to look closely at important elements that facilities can use to build robust sepsis programs. Each 1-hour webinar will discuss key features of effective sepsis programs and include examples from CDC partners sharing strategies, real-life examples, and best practices for successfully implementing one or more sepsis program core elements. Today's webinar is the second of 5, and we will focus on 2 of the core elements, accountability and multi-professional expertise. We will be hearing first from 2 of the creators of the core elements who will outline the importance of having a leader or co-leaders responsible for program goals and outcomes. Next, they will look at how to engage key partners with different areas of expertise throughout the hospital and healthcare system. In addition, we have 3 clinical experts who will provide real-world examples of how their programs have successfully implemented these 2 sepsis core elements at their institutions. Lastly, we have gathered questions during registration and will take your questions throughout this program. We will ask the experts to address some of those today. I'd like to first introduce our 2 our 2 subject matter experts from CDC and University of Michigan. Dr. Ray Dantes is a medical advisor in the Division of Healthcare Quality Promotion at CDC and an associate professor of medicine at Emory University Hospital, where he practices hospital medicine. Dr. Dantes provides technical assistance to CDC sepsis epidemiology studies and educational efforts, and partners with other leaders in sepsis to advance the field of sepsis surveillance. Dr. Hallie Prescott is an associate professor in pulmonary and critical care medicine at the University of Michigan and a staff physician at the Ann Arbor Veterans Affairs Healthcare System. She works clinically in the medical intensive care unit and outpatient pulmonary clinic. She is an internationally recognized expert in sepsis management and outcomes. She serves as the co-chair of the Surviving Sepsis Campaign Guidelines and physician lead for the Michigan Hospital Medicine Safety Consortium's sepsis initiatives. These two sepsis experts will explain what the core elements of accountability and multi-professional expertise are and how to incorporate them into a successful sepsis program.
Thank you. We'll pause here briefly for some additional disclosures. Next slide, please. Recently, we published a report in the CDC's MMWR journal that highlights findings of a survey of over 5,000 US hospitals regarding their sepsis program practices. Next slide, please. This graphic contains some of the highlights from this article that form the background and basis for the core elements. We found that 73% of US hospitals currently have a sepsis program. Only 55% of hospitals provide dedicated time for sepsis program leaders, and a little over half of sepsis programs involve the hospital's antibiotic stewardship program. Next slide, please. With this background, we'd like to highlight the purpose of the hospital sepsis program core elements. These core elements provide guidance for monitoring and optimizing hospital management and outcomes of sepsis. It's the blueprint for how to build a successful hospital sepsis program. There is an emphasis on leadership support, personnel resources, quality improvement tools, and implementation science. The core elements are most importantly intended to complement existing sepsis guidelines and facilitate their implementation. There's additional emphasis on sepsis management throughout the hospitalization and recovery process as well. The intended audience is US hospitals and hospital systems, and we think the core elements are applicable regardless of the hospital type and population. Next slide, please. The CDC Hospital Sepsis Program core elements are available now on the CDC website and include the following materials: the main core elements document, an assessment tool, which is a checklist that you can use to evaluate your use of the core elements, and many supporting materials. I'll now turn it over to my colleague, Dr. Hallie Prescott, to give an overview of the core elements and the focus of today's discussion.
Great, thanks so much, Dr. Dantes. This infographic summarizes the 7 core elements. The first, hospital leadership commitment, speaks to having hospital leadership involvement in the hospital sepsis program to ensure that the program has the necessary resources. This was the subject of the first webinar in this series. The next core elements are accountability and multi-professional expertise, which will be the focus of today's webinar, and I'll talk about in more detail in the coming slides. The next core element is action, which speaks to the structures and processes in place to carry out optimal management and outcomes of sepsis. These include things like order sets or documentation templates, care pathways to facilitate implementation of best practices of sepsis in your hospital. Tracking speaks to measuring the epidemiology, management, and outcomes of sepsis in your hospital and tracking progress towards your hospital sepsis program's goals. Reporting goes hand in hand with tracking and speaks to reporting the information that you've tracked back to hospital stakeholders. And education speaks to educating healthcare professionals and patients, families, and caregivers about sepsis, its symptoms, and its treatments. Next slide. I'll now go into more detail about examples of the accountability core element. Accountability has 2 big pieces. The first is ensuring that there are 1 or 2 dedicated leaders of the hospital sepsis core program, and 2, that the hospital sepsis program is setting definable goals and that those are being reevaluated each year. In terms of specific examples of the accountability core element, the first is identifying a single clinician leader or 2 clinician leaders who will be responsible for sepsis program management and outcomes. The next is setting ambitious but achievable goals for improving sepsis care and outcomes that are informed by review of the hospital practices, the hospital sepsis outcomes, and updated clinical practice guidelines. Ideally, these goals should be specific, measurable, achievable, relevant, and time-bounded. The next priority example is assessing progress towards the hospital sepsis goals at regular intervals, such as annually, and updating those goals periodically to promote continual improvement in the hospital. The next example is identifying a physician or nurse leader or champion at each hospital. And this is for hospitals where the sepsis program may be organized at a health system level, such that the clinician leader or co-leaders are for the entire health system. In those types of situations, it's important that there always be a physician and nurse champion within each hospital. Next slide, please. Additional examples of accountability include having sepsis program-related activities and outcomes in the annual performance reviews for sepsis program leaders, identifying unit-level physician and nurse champions, and then reporting the sepsis program activities and outcomes to senior leadership and/or the hospital board on a regular basis. Next slide, please. I'll now talk to the multi-professional expertise core element. Sepsis is a disease that can occur to any patients throughout the hospital. And so it's really important that the hospital sepsis program includes a broad stakeholder group. Priority examples to demonstrate multi-professional expertise include having a sepsis coordinator who is in charge of day-to-day implementation of hospital sepsis program activities. Collaboration across key hospital locations, such as the emergency department, the hospital wards, and the intensive care units. The next is engagement of multi-professional expertise, including nursing, emergency medicine, critical care, hospital medicine, and other primary hospital services, such as infectious disease, pharmacy, and social services. The next core element speaks to engaging hospital antibiotic stewardship program to ensure that antibiotic recommendations for sepsis are tailored to local data, and include discontinuing of antibiotics once they are no longer indicated or needed. The final priority core element is engagement of relevant support services, including individuals with expertise in quality improvement, implementation science, information technology, and analytics. Next slide. The additional example of multi-professional expertise is having ad hoc domain expertise. This would be individuals who may not need to be at every single meeting of the hospital sepsis program, but can provide relevant input on an as-needed basis. This includes individuals working in case management, microbiology, phlebotomy, outpatient clinics, hospital epidemiology, infection prevention, and then patients, families, caregivers, and community members.
Thank you, Dr. Dantes and Dr. Prescott, for sharing about these concepts and the importance of gathering healthcare professionals dedicated to improving sepsis programs in their facilities. Now let's look at some examples of how to implement sepsis program core elements in a real facility setting. Our first panelist is Colleen Drolet, and she is the HMS Sepsis Nurse Abstractor for Henry Ford Jackson Hospital in Jackson, Michigan, where she previously worked as sepsis coordinator. She is responsible for sepsis data abstraction and involved in quality improvement activities. In her wide clinical background, she has worked in quality improvement, in the development of stroke and trauma programs for McLaren Greater Lansing, and was a consultant for the Kaiser Permanente Health System at their South Sacramento and Oakland sites. Colleen will be sharing an example sepsis program at Henry Ford Health in Jackson, Michigan, and she will share details on how the program is structured in terms of multidisciplinary roles and how each role is accountable for optimizing the delivery of care for patients with sepsis. Colleen?
Hello, everyone. Good afternoon. I'm going to be speaking on the things we did at Henry Ford Jackson as we developed our sepsis program. I'm hoping that this especially helps folks at hospitals who are just starting on their sepsis journey or are kind of new to it. Next slide. Oh, no, you're at the right slide. Sorry. These are the key points I'm going to talk to you about today. Organizational structure of our program, engagement of key partners, specific roles and expectations of our leaders, goal setting, monitoring progress, revising goals, and then some of our challenges and successes. So first, organizational structure of our sepsis program. We have a dyad leadership structure of a physician champion who is an ED physician and a sepsis coordinator who's a nurse. The physician has certain time dedicated to sepsis, and the coordinator position is a full-time position dedicated to sepsis. This slide shows our steering committee, our sepsis steering committee, and that includes an executive sponsor, nursing leaders, physician leads from the ICU, ED, and the floors, and we also included our physician residents. This committee functions as a steering committee, and it drives care throughout our hospital. The members set the goals every year, they review the data and ensure compliance. They make the protocols, ensure the EMR is sepsis friendly, and they identify or create or modify workflows. We report our SEP1 data every month at this meeting. We review how we compare to other hospitals in our system and at the state and national levels. And we discuss our successes and our challenges related to the SEP1 bundle. If you're just starting out, you may even want to summarize some of the specific reasons for fallout. This, according to the SEP1 bundle, because it can help identify trends. Our current goals at our organization are improving the SEP1 compliance and reducing sepsis-related mortality and readmissions. From the steering committee, we developed 3 work groups that perform the actionable items, and they focus on the ED, the ICU, and our sepsis unit, which is a med-surg unit. This helps keep the steering committee just that, a steering committee. It allows the work groups to focus on actionable items relative to their specific area. For example, the ED work group focuses on SEP1 bundles and their shock cases. The ICU work group focuses on SEP1 as it pertains to the ICU and mortality cases for their septic shock cases. And the sepsis unit work group focuses on inpatient code sepsis cases and readmissions. The work groups also have ad hoc members such as case management, palliative care, et cetera, for situational issues or projects. Our sepsis steering committee reports up to our system sepsis committee at Henry Ford, and the work groups at Jackson report to our local Jackson sepsis steering committee. I think if you're starting out, the development of a sepsis steering committee is a place to begin, and I would suggest that you focus on the SEP1 bundle and identifying your workflows surrounding sepsis, and maybe perform a gap analysis to see where you're at and compare that with what's happening with the SEP1 bundle. Number 2, engagement of our key partners. It was especially important in the beginning, and it continues to be, that we have the right people at the table when making decisions about sepsis care. In addition to the leaders and specialties mentioned in our sepsis committee, it's important to involve the clinical staff doing the work. We do not want to create workflows that do not involve our bedside staff. If you're new to this journey, I highly suggest including your bedside staff or at least a representative on your sepsis committee. I also suggest involving your bedside staff, be it providers, nurses, lab, pharmacy, when you are reviewing your EMR and your policies and your workflows that surround sepsis. For us, the code sepsis process, which included our nurse-driven protocol and the sepsis narrator, are notable examples of that. That required engagement from our local staff, since they are the ones calling that code sepsis and using that specific tool. Number 3, specific roles and expectations of our leaders. The sepsis coordinator coordinates the program, ensuring that the policies, the protocols, and the EMR tools are in place that support the care we provide. She co-leads our sepsis steering committee, provides education, partners with the physician champion, educates the community and the staff, and acts as an essential point person for the program. The physician champion for sepsis acts in partnership with the coordinator on all those activities and works to ensure that the providers understand the data and support the changes that impact our providers. Our physician leaders review cases and engage the physicians with what's done well and/or opportunities that were identified. The other leaders are responsible for taking back to their staff what's learned in the sepsis, our system sepsis meeting and our local sepsis meeting. For the work groups, each leader is a nursing manager of that specific area, along with the physician champion for that area. Additionally, the leaders are responsible for follow-up on the fallouts from the SEP1 bundle. Number 4, goal setting. Next slide, please. We set goals at the system level for our SEP1 compliance. We base this on the data that we collect each month for our sepsis patients for the CMS measure. At the end of 22, we at Jackson worked with our system sepsis program leaders and set mortality goals for our hospital for 2023. And we're getting ready to set those goals for 2024. At the same time, our work group set their goals as well. This is an example of a dashboard for our med-surg, our sepsis unit work group. The numbers are fictional, but it gives you an idea of what this work group looks at every month when it meets, and also reports their progress and or barriers back to our sepsis steering committee. So this work group, as I mentioned, was looking at those readmissions. They may also look at other things. For example, they're looking at length of stay and the volumes on that sepsis unit. Number 5, monitoring progress. As I mentioned, we monitor our sepsis data monthly. We provide real-time feedback as much as possible to our providers, including our residents, our nurses, our lab, pharmacy, because it's easier to discuss those cases with staff when they kind of remember that patient. It's a little bit harder to do 3 months back. We also celebrate successes and give that feedback. I think sometimes that's equally as important as talking about the opportunities for improvement. Number 6, revising goals. Very simply, we revise goals when necessary. We don't continue to monitor things for endless periods just for monitoring's sake. And lastly, challenges and successes. Challenges, step 1 is complicated. Sepsis is complicated. I have an exclamation point over that in my notes. Step 1 gives us a lot of specifics, but or it gives us a lot of data, but not a lot of specifics. So it takes resources to really delve into those cases to find the root causes for those fallouts. Another challenge is that there's competing priorities for all of us. There's so much work to do around sepsis, but it's not the only thing. With the pandemic and staffing shortages and turnover and burnout and all the things, it's important to keep projects and goals manageable so that progress can continue to be made and our leaders and our staff aren't overwhelmed. And then successes, I have to say, hands down, our most significant success is the engagement of our staff. Our bedside clinical staff, physicians, nurses, all the clinical folks are very dedicated at our organization to sepsis. They're proud of the work we do around it. We have a sepsis unit with staff that is dedicated to providing care to these patients. And we also have leadership that really support our staff in the work that they do around sepsis. I'd like to end by saying that we at Jackson did not do one big thing. We did a million, continue to do a million small things. And I think that means that it's doable for everybody then. You just have to start. Thank you.
Thanks, Colleen. That was a wonderful presentation. I can't wait to get more into that as we get on in our discussion portion. Next, we have Isabel Friedman. Dr. Friedman is an assistant professor of science education at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell and an adjunct assistant professor in the Francis Payne Bolton School of Nursing at Case Western Reserve University in Cleveland, Ohio. She currently serves as the principal for process improvement for the Department of Clinical Transformation at Northwell Health, where she serves as the nursing chair on the Sepsis and Advanced Illness Collaboratives. She will be sharing the Sepsis Collaborative across 21 hospitals who make up Northwell Health in New York State. She will detail how the Sepsis Collaborative is structured and the successes and challenges since inception. Dr. Friedman?
Thank you very much for your kind introduction. So today I'm going to share with you Northwell Health Sepsis journey, which began in 2008 and continues today. I will share how our journey pertains to the second and third CDC Sepsis Hospital core elements following this agenda. Next, please. Northwell Health is the largest healthcare provider in New York State, consisting of 21 hospitals and 850 ambulatory facilities. Next, please. In 2008, Northwell Health prioritized sepsis as a system-wide initiative, and that continues to this day. We use the collaborative model as our structure and implemented PDSA as our primary improvement strategy. The collaborative relies on the collective knowledge of its participants, builds on the sharing of progress and experiences of all facilities. The collaborative is supported by an internal faculty of subject matter experts providing evidence-based updates and assisting in setting the educational agenda. The structure is both top-down and bottom-up. Accountability for sepsis care rests with our senior executive sponsors and flows systematically down to the sepsis team. These teams are the boots-on-the-ground heroes at the site. They are the ones doing the process improvement work based on their individual site needs, and these are based on their specific bundle element data. The bundle element data is presented in a sepsis-specific Tableau dashboard for the entire health system that can be sorted by site and date. The information collected and outcomes are reported up to the sepsis leadership and ultimately to the board. To support this effort, the sepsis teams are provided with a dedicated sepsis platform staffed with analytics specialists, clinical experts, and a dedicated improvement sciences team. All this support provides a strong framework for taking action to achieve, sustain, and disseminate information on breakthrough improvements through monthly meetings and quarterly sepsis educational sessions. Next, please. Northwell feels that accountability is more than just being responsible for sepsis care, but it is important to feel a sense of ownership. Some of our supports for accountability and ownership include an organizational scorecard, setting of organizational goals, monitoring our performance and data, our performance data and outcome data using our dedicated data abstraction tool, which provides consistency and accuracy to all the abstractors. Having site-specific nursing and medicine sepsis leaders and sepsis champion program. The initiative is focused on the ED. That is where 75 to 80% of Northwell cases present, and then we have expanded the initiative to the inpatient unit. Next, please. The importance of multi-professional expertise cannot be stressed enough. All hospital sites have active sepsis teams that meet at least monthly and consist of physicians, nurses, data analytics, and IT specialists. They include members from the pharmacy and the lab who attend on an ad hoc basis. Teams share their improvement projects at the organizational level via monthly collaborative calls that allows us all to communicate our best practices. They can be tweaked and utilized for the specific needs of other teams depending on their size. I have enumerated other examples which are on this slide. Next, please. So what have some of our successes and challenges been over the years? Successes. The collaborative model and its structure have provided us with a foundation for substantive improvement in care processes, utilizing a focus on bundle elements, which we then use process improvement in real time and share that information across all our sites. Dedicated and educated clinical abstractors input data via our specialized tool into our sepsis database, which populates into our sepsis dashboard. This assures accuracy and decreases bias and error in our data, ultimately making it transparent throughout the entire organization. Outcome measures such as mortality and equity are also monitored for trends and further analysis via this Tableau website. Northwell's participation in state, national and international sepsis initiatives helps to keep us up to date with the latest developments. For example, we have active participation in the New York State Sepsis Advisory Council. Ipsos, a national pediatric sepsis organization, is also another one of the organizations that we belong to. And the End Sepsis campaign, which is an international organization which Northwell has been a proud participant in since its inception in 2012. Of course, like everyone else, we're certainly not perfect. We can all agree that COVID has a significant role in derailing many of our normal day-to-day healthcare workflows. Just like Dr. Drolet mentioned, we are still regrouping and revising our sepsis initiative after the COVID interruption. Loss of experienced staff that held great sepsis knowledge and institutional sepsis history is one of the major losses. Hiring, onboarding, and educating new staff is a continuous struggle. We will try to work with HR to specifically include sepsis activities in our team member appraisals. Our aim is to increase critical care and assure multidiscipline representation on the site sepsis team, but that does remain a challenge today. Next slide. In summary, it has taken our organization over a decade to establish a system to decrease sepsis mortality. This slide represents all our work from our baseline data collection year of 2008 to the present. We reduced sepsis, severe sepsis, and septic shock non-risk adjusted mortality by 50%, from 32% to 16% in 5 years, and have continued decreasing until 2019, when we reached our stretch goal of 10% mortality. That represented a 66% decrease from 2008 to 2019. I will draw your attention to the red lines on the graph. This reveals the disruption COVID caused between 2020 and mid-2021. Since Q3 of 2021, we appear to be heading in the right direction. We've achieved a 12% mortality in mid-2023. Sepsis awareness, early identification, and prompt treatment continue to be our focus. Next, please. Thank you very much, everybody. And we'll discuss some questions later. Appreciate your time.
Thanks, Dr. Friedman, for sharing your data and your successes and challenges. As a reminder to our audience, please put any questions regarding any of the speakers' presentations or the core elements in general into the Q&A box on your screen. We look forward to having questions to discuss during our next few periods. And lastly, for our final presentation, we have Dr. Nicholas Kuhl, who is a board certified in emergency medicine and a clinical associate professor for the Corewell Health MSU Emergency Medicine Residency Program. He is the System Emergency Services Medical Director for the Corewell Health West Group of 11 hospitals. He has co-chaired the CH West Sepsis Expert Improvement Team since 2018, which designed and launched a novel code sepsis process. The efforts cut sepsis mortality in half, an accomplishment recognized by the Michigan Hospital Association with their 2019 Advancing Safe Care Award. Dr. Kuhl will be sharing an example sepsis program at Corewell Health in Michigan. He will share details on how the program is structured and how the team reduced sepsis mortality by engaging multiple diverse groups in sepsis care delivery. Dr. Kuhl.
Thank you very much. Yeah, I represent Corewell Health West, and we're a group of 11 hospitals. We're kind of centered around a large institution in Grand Rapids, our Butterworth site, that has 850 inpatient beds and over 100,000 ER visits per year. And that's where we began our work in sepsis and then spread it to the rest of the system. We were somewhat stuck in 2015 through 2018. We were wanting to improve our mortality, but we were stagnant at 27%. We had teams working around the edges, but we struggled with variation in process. There was mixed reviews of the evidence and guidelines, and it was time for a reinvestment. Next slide. So our leadership at that time decided that fiscal year of 2019 was going to be a focus on sepsis care, and that would be one of our strategic quality goals. And they tasked the acute care service line with ownership of this goal. And that was a physician leader and an operational leader that together oversaw our ER, our hospitalists, our acute care surgeons, and collaborated with our ICU to take this goal and make it happen for our hospital. With their support, we created a business case and decided it was time to hire a sepsis coordinator. And we found an excellent colleague, an RN sepsis improvement specialist that joined our team. And it's cut off slightly on my screen, but we set a goal number 3 was that we needed to reduce sepsis by 20%, reduce the mortality by 20% in that first year. So we tried to push ourselves. Next slide. This is some of the outline of our expert improvement team that we established at that time. We had the improvement specialist, full-time equivalent at that time. And then we recruited an ICU and ER medical director that already had a significant kind of 0.5 FTE protected for quality initiatives such as this. Those two were going to be the chairs of the work, accountable to the outcomes, and we're going to lead the team as we move forward with our ambitious goal. You can see the next 2 lines, light blue and green, all the critical professionals that we had to have part of our group if we were going to make a difference. Pharmacists that understood the process of getting an antibiotic to the bedside, what barriers there are in timeliness, antibiotic stewardship expertise that they brought, hospitalists and residency team members that joined us, nursing leadership, as well as bedside RNs. And we needed our team to support that they could badge in and they could get paid for their time working on our work group. You can't do this just with volunteer hours if you're going to make a big difference. And then finally, the light green row, just the critical support of infrastructure around our system. The leaders found team members in these groups and told them that this is a priority now. You need to take this and put it at the top of your list. There are some things that we are going to accept move down because now sepsis is a goal for you. And their engagement was so critical as we move forward. We even leveraged like a rapid improvement event. And sometimes you can do it over a few hours. We did it over a couple of days, and we paid for everyone to be there. They needed full dedication of their intellectual creativity to improve our work and achieve the outcome we were going for. Next slide. This is just an example of one of the outcomes of that rapid improvement event. Initially, we produced it on a 1-page guideline that nursing, provider, pharmacy, everyone could look at in the moment and make sure that their role was well defined and they knew how to win, how to get it done for that patient. We brought together, you can see the green boxes are kind of examples of that multi-specialty expertise. We agreed as a physician leadership team, what do we define as code sepsis? Who meets that criteria? How are we going to find them even at triage? We then said, what is our goal? What are we going to do at the 15-minute mark, the 60-minute mark, the 90-minute mark? And then we even structured that admission handoff. How do we make sure that the right pieces of information are discussed every time so that the pedal stays to the metal on these patients? We don't let up as they get up to the floor. The yellow and purple boxes just show that kind of multi-professional expertise coming into this work. Nursing roles, pharmacy roles, reassessments, and even informatics. The purple box is just examples of how, while we outlined this on paper, we immediately started the process of building it into the EHR, wrapping our order set around it, creating a sidebar that turned green every time one of your goals was achieved. Just examples of the output. Next slide. And when you have this major effort and you are making a difference, you want to know if you're winning or not. You want to know, does it make a difference? What you see here is just an example of the baseline effort, which is CMS fallout reviews, necessary and important, but the data is not timely. We all know that. When you add a sepsis improvement specialist, we built in a weekly cadence where we could review every single case that came in that prior week, both the ER cases and the hospital identified cases. Our coordinator would sit down with me, we'd go over in detail, and the major benefit was twofold. One, that timely feedback. Here's the opportunity. Here's the tool in the EHR you didn't know about that you could leverage next time, but also the wins, knowing all the success that was out there that you don't see when you only look at fallouts. So we sent thank you letters. We put out sepsis champions for the month and a variety of positive feedback to help change that culture. Next slide. And then from a sustainability standpoint, we needed that big picture data. And I heard Dr. Friedman talk about Tableau as well. This is where we can get an automated data pull from the EHR to track kind of the 3,000-foot view how are our teams doing month to month, year to year, and where do we need to emphasize, efforts to change, recognize a trend before when we still have an opportunity to intervene, and then also, can we drill down on this? We made it so that you can get all the way down to the MRN or to the provider attribution. So I can search one of my ER providers and give them, hey, this is your 8 cases from the last year. If you want to deep dive them, great, but just pay attention to this. I appreciate it. And here's your own review. Next slide. We've obviously had success. We've been proud of what we've accomplished with this collaborative effort. And this is just the outcome. We started in Grand Rapids and we spread it to the 11 hospitals around West Michigan that we were responsible for. And our mortality for ED sepsis outcomes there across the entire group dropped significantly, as you can see. Last slide. So with success, you spread it. Obviously, we brought it to our other hospitals. We received a little award for the work, and we're proud that mortality is stabilized at about 10%. But you can also lose some of the best people when they demonstrate what they're capable of. And we did get our sepsis collaboration, our specialists got reassigned to another team because the hospital had other priorities. All of a sudden, we were now in a place where we could maintain and lost that resource. And that's acceptable. We all live in environments of limited resource. And so we have to navigate through that. And you can see what we do now. We educate new team members as they come on board. We review our clinical pathways on a regular cadence. We adjust our EHR tools to align with the changing CMS core measure. And then we give the feedback when we have it. The timeliness of these new core elements struck me because it's about time for Corewell West to engage and invest again. And I see opportunity within the outline that Hallie presented for us today. So excited to see where we go next. And thanks for hearing from our example.
Thanks, Dr. Kuhl, and thank you all for showing how you've leveraged these 2 key elements into successful sepsis programs. I'd like to start the conversational portion of this event with a question from one of the participants watching today, and it actually ties back to what Dr. Kuhl, you were saying about limited resources. So this first one discusses the position of that important sepsis program coordinator. So should sepsis program coordinator positions be prioritized for a successful program? And is it possible to have a successful sepsis program without dedicated staff with protected time to do sepsis? Dr. Kuhl, I know you just spoke, but if you could maybe talk to your example of having the limited resource there, and then we'll open it up to the other panelists.
Personally, we found it critical to have, for us, it was a full-time coordinator to launch a new initiative like this. We were trying to, steer the ship of a 850-bed hospital, large provider teams that all needed to adjust their mindset a little bit. And without the insight into that weekly review and that feedback, both opportunities and celebration, I don't think we would have had the success that we had. So I feel like it's critical, especially to launch an initiative like that. We are managing in that maintenance phase, but I see opportunities that arise right now that I don't have capacity to pursue every single time. And I know it's because we're in a lean environment, resource rise. So I'm hoping for reinvestment, but I think you can do it. What you can't do is do this on volunteer time. If it's a provider, if it's your nurses, if they're just doing it off the side of their desk, I don't think you're going to see the change. So even if it's not a full-time equivalent, you have to at least protect the hours of the team members that you want to engage.
Thanks for that helpful lesson on how to maybe, in those lean moments, like you said, to work without a full-time sepsis program coordinator. Dr. Friedman, do you want to talk about your experience a little bit?
Certainly, I agree with Dr. Kuhl 100%. I believe we with the structure that we actually have with our collaborative model, we do have myself, who's 100% involved with the sepsis collaborative on a nursing level. I have 2 physicians who have dedicated time but are not 100%. The problem comes in at the hospitals. We, as Dr. Kuhl, we have a lot of hospitals of all different sizes. If you have a very large hospital, you probably needs dedicated people or dedicated position to do the work of the sepsis collaborators and making sure the data comes in and the teams are doing what the teams are supposed to be doing. That being said, I know that there's an awful lot of work that needs to go into a hospital of any size. So the position should be a full-time position, whether it's 1, 2, or 3 people. They should be working in concert, and that helps sometimes because if you have someone doing it full-time and no one else knows what they're doing, when they leave, you have a heck of a time trying to get the next person up to speed. And so you do need someone, and depending on the side of the hospital, I think the dedicated time would be different.
That's a good point. I've heard the thread of communication being very important, both on a weekly or monthly basis, but also as this role might transition from person to person. Colleen, I think you have the unique experience of having been a sepsis program coordinator. Can you share your thoughts?
I'd be happy to. I agree that it really should be a dedicated person. The only exception might be the really, really small hospitals that don't have a lot of cases. But I think like my elevator speech to a leader would be sepsis is different from things like stroke or trauma because it touches like so many patients in so many areas. And it's complicated. It's not an easy bundle. And we're still learning clinically about it. And so it's different than other programs in that regard. It takes a lot of resources to delve into cases to find out actually what's happening at your organization and why, and do you need to fix something or don't you, or and giving all that feedback to staff, providers and nurses and the other clinical folks is essential, but that's a lot of resources. So that would be my elevator speech in trying to convince leadership to support a dedicated coordinator position.
I appreciate the practicality of that. Sometimes knowing the right words to say and the right way to say it can make all the difference. Dr. Dantes, I would like to ask you this question here. It branches a little bit more into the totality of the core elements. So how can facilities track their progress with the core elements?
Thank you. So we created a core elements assessment tool that's available both at the back of the core elements document and as a separate link on the core elements website. So I encourage users to check it out, to use it as a guide for tracking which parts of the core elements they've been able to complete. Thank you.
Thanks for that. I want to ask another question that has come in. We must have some pharmacists that are interested in being involved. And one was how we can involve pharmacists. I know, Dr. Kuhl, you specifically had pharmacists on one of your slides as key stakeholders. Can you perhaps start and talk about how your system utilized pharmacists and how they can be key players in this?
Yeah, at Corewell Health West, we have kind of 2 different roles of pharmacy that's really been useful in this work. One is our antibiotic stewardship pharmacists, and they bring an additional expertise on the right antibiotic that both checks the CMS box, but also meets the patient need, given a first, a second, a third line choice. You have to navigate allergies, and then also within the source you're anticipating. So we kind of built our order set, our sepsis order set, and the treatment phase was like, all right, what do you think is going on? What are you going to pick? And what if you have 0 source, but you know they meet criteria? What's our first, second, and third line? I couldn't just do that myself. Their expertise was amazing in helping us build that out. And they help us keep it up to date too as things change. The other role that was really useful is the bedside pharmacist. So there are pharmacists that support our larger hospital in the ER 24/7. We have smaller hospitals that don't have any pharmacy in the ER. But knowing what those resources are, how the antibiotic that you order makes it to the bedside, how that nurse knows that it's ready to go, and how it gets charted off, walking that process through with our pharmacist I learned a lot, and we were able to shave minutes off of that from the decision to treat to getting the drug in place and making that patient better. And then they helped us know how to adjust for the limited resource facility. Where are those antibiotics? If no pharmacist is bringing it, how does the nurse get it? So those two roles were really useful as we built our process.
Thank you. One last question. I'll open it up to the group and see who's brave enough to take it on. I think it was mentioned there that it's important to reassess your goals as you go through. And I'm sure there's no magic timeline as to when reassessment should occur. But if a couple of you could just talk about how you decide at what point it's time to reassess whether things need to change or whether you've perhaps mastered a particular goal and can move on to something else. Dr. Friedman.
So that we do on a site-by-site level because they're all different, small hospitals, large hospitals, they focus on their own individual challenges. And so when they do the PDSAs, when they actually finish a PDSA, then that goes into the control phase and they just monitor that and they move on to the next challenge. So the organizational goals are done annually, and our ED, as Dr. Cool is an ED expert, we do have an ED chair of our collaborative, and they help the ED service line to set the standards for their annual goals for each and every one of our emergency departments across the organization.
Great. Thank you. Anyone else? Yes.
Sure. It's been slightly more fluid here at Corewell Health, and we began with a more kind of monthly and then quarterly cadence, especially as this was a strategic goal for the system, and we were celebrating our wins. And then as we got into that maintenance phase, it was twice a year I was presenting to our board on what our outcomes were and what our more recent interventions were. With COVID, some of that went away, right? The focus shifted, but again, it's kind of time to reestablish that regular touch base and reestablish those goals for us.
Great. Well, I want to thank you all for all those wonderful insights and for sharing with me and our audience your individual programs and how you have made amazing strides in sepsis. And I'd like to wrap up this event with some key takeaways. Recruiting a physician and nurse to co-lead your sepsis program offers many benefits. Local champions have the respect of their peers and can lead effectively within well-delineated roles. In addition, setting ambitious goals and monitoring progress create an environment where everyone strives for continual improvement. The rest of the sepsis program members should represent diverse clinical areas and support services. Hospital sepsis coordinators oversee the day-to-day implementation of the sepsis program activities and provide visibility to the program. Engaging healthcare professionals from various hospital locations, laboratory, emergency department, pharmacy, and hospital medicine, to name a few, allows a variety of viewpoints to ensure all aspects of sepsis identification and management are considered. As a reminder, a recording of this webinar will be available on this page shortly. We have drafted a PDF of information, websites, and links related to our discussion today that we hope you find helpful. You can locate this in the top left corner above the video in the Resources tab. Another big thank you to our audience today for your desire to reduce the morbidity and mortality associated with sepsis. Recognizing and treating sepsis requires us all to be vigilant, and by working together and utilizing these core elements, we can keep our focus on better patient care and outcomes. Part 3 in this 5-part series will be on November 2nd at 1 p.m. Eastern Time, and we will examine the element of action, where we look at how to implement structures and processes to improve the identification of, management of, and recovery from sepsis. We look forward to answering more of your questions there and fostering this online community of learning. Thank you and have a great afternoon.